So just to give a little bit of context, a little bit of background, as some of you know, over the past probably 3-4 months, members of the field team and Melissa and myself had conversations with you all over the phone in prep for this conference, talking about the creation of that space, whether it be a steering committee, an executive committee, whatever you want to call it. Name's not as important to us, but a space for those voices, for that sort of leadership. And we spoke to many of you guys about it. Some of you guys were able to also talk to chapter members about it. Some of you in this room might be hearing about it for the first time. But the overall feedback we got was pretty positive, that people thought this was valuable, that it would be a good undertaking, that they'd seen it happen in other organizations and be fruitful. But also people had a lot of questions. What would it do? How would it be organized? You know, I'm very busy. I don't know if I could commit to it. What's the sort of commitment you're asking for? So that's really kind of up in the air, and we want to continue some of those conversations. So the overwhelming response, though, was yes. This sounds like a thing worth doing. And when we asked, you know, what do you like about it? What are some of the things of value that you'd see in creating this space? Folks talked about connections, creating connections across the country between different leaders, opportunities for training, opportunities to really influence the direction of PCP, opportunities to determine national campaigns, things we could do together, right? We can't do everything, so we've got to pick. So what would some of those things be? So I wanted to just take a minute or two to make sure we're not missing anything from that. From your perspectives, what would be the value of creating this space? Or if you don't think it's worth creating a space, you know, love to hear that as well. So not necessarily what are we going to be working on and how would this be structured, but you know, what is the value of this, the why piece? Why would it be worth doing this? So any thoughts or reflections on some of those things that you see up there? Yeah, please.
I think that it's something I've seen other national committees do, but sometimes a school does something and it's awesomely successful. And I think a national committee, in a way to communicate that back and kind of spread almost like best practices. So like the same way that, you know, the Montgomery bus boycott realized that Baton Rouge had an amazing carpool that they set up and asked them for help with it. I think that there's a kind of a way to spread, yeah, like best practices. And I think that a national committee and relaying that back could be a good way to do that. Awesome,
thank you. And two comments. You did a great job speaking up. Voop is not here. She's in a meeting, so I'll speak up. And feel free also to not only talk about why this is important, but what you would actually do, just like you did. So let's keep the conversation going. Yeah, Ming, please.
Kind of going all the way back to why I first got inspired by PCP is the notion of creating this vast network of people from all different backgrounds and training levels. And that really got me inspired by this movement and also sort of the potentiality of creating big change. And I really like this idea because if, for example, medical students from a chapter are way too busy to do a project, perhaps a part of your project can involve undergraduate help because we probably have a lot more time and we have you know, this sort of naive energy about us that we can just go forward without even thinking. So if you guys need any help from us at all, like we would be more than happy to work with you. And I think undergrads always look up to you guys, so I think having that relationship would be very awesome.
Well, Ming, I think we see you as part of the us. Yeah, please.
I mean, going off of that, one of the first events that we had this year was called a meet and eat, where undergraduate students could get together with medical students and talk about what sort of transitions you went through and things like that. Like, I completely agree when I say that undergraduates are dying to tap into y'all as a resource. And I know you want butts and seats for these town hall meetings and just getting numbers out to convince the higher ups that there is a desire for primary care to be a focus. So I just second that.
Excellent. Other thoughts on the why piece? Yeah, please.
I I think my first thing I first responded to was the culture, the youth culture here. Kind of, I mean, in a range of younger people.
The youths.
The
Youths.
youths.
What?
I don't know, like, you know, I've been to, you know, like the North Carolina, a lot of stuff in North Carolina with AAFP, NCAAFP, and, you know, a lot of that stuff is, you know, with primary care change in the air is, you know, the PCP talk, or primary care medical home, electronic record talk, which to some extent is over, I'm like, still over our heads, because we're not there yet. So I appreciated the young conversation. I also, I think in the end, wanted a little bit of the context of folks who, you know, who have been practicing for 40 years and what they would think of a training like this, or, you know, what they can offer. And I think I kind of expressed that earlier. But I think the why, you know, capturing that this is something you can do, this is something you can start now, and it's not about, you know, waiting to your 40 years into practice to start your patient-centered medical home, which is the other focus. So I think that's a why and a want.
Excellent.
Yeah.
Yeah, please.
I think that why a national committee might be important a thing to form is something that Sarah mentioned earlier, was that she felt like PCP didn't really have a story of us, and you guys all have stories, and you guys have obviously probably behind the scenes have a story of us, but that maybe a national committee could sort of put that out and create a sense of urgency and sort of draw from all of our personal stories, the personal stories of our members, our chapter story, and kind of create this larger national vision. And that could sort of be like I keep using the term landing place with my group, but like a sort of a landing pad for people to come and bounce off of, and like bring everything together and launch from there.
Yeah, excellent. Yeah, please.
So something I've kind of noticed with all the healthcare reform talk and politics is the AMA, and I feel like physician groups in general, I feel like are not advocating as much for primary care in this whole conversation as much as we really need them to. I mean, I think it's slowly coming about, but for the most part, the AMA is run by specialists, and I feel like this is a good opportunity for us as a younger cohort of doctors and medical students and pre-medical students to contribute to the whole healthcare reform conversation. And really, the only way to do that is to have a national group that could then put out a policy statement or like the AMA does, but focus more on primary care.
Some of my best friends are specialists. Amy, did you have your...
Well, they pretty much said it, but I was just going to say, I think what the National Committee would do is create legitimacy to our organization as a national voice, instead of saying, oh, we have this leadership in Boston, and then we've got these peripheral or chapters, so we really are creating a national voice.
Love that. Yeah, please.
I think it's really important that as that leadership committee comes about, that they really reach out to organizations like AAFP that really has been talking about this for years, not alienate them in any way as you go forward.
Absolutely. And Ashley Beek, who's here with the Family Medicine Interest Group Network of AAFP, we've been working closely, and I think we're just looking to do more work together and build the collaborations and the opportunities. But it's a great point that we're the new kids on the block in a lot of ways, and there are other organizations who've been working on this issue for decades, and we want to be sort of the spackle in a lot of ways, like find out what hasn't been happening and how do we come in and help as opposed to right. That's a great point. There was Joe, did you have your?
Yeah, I really like, and this is part of being a new organization, I really like the heterogeneity of our ideas and our current projects that are going on. I mean, there's a huge range of things that's happening. And part of me is a little bit afraid of that going away if we have a national committee that says, okay, this is the consensus direction of PCP. But it would also give us, but the plus side would be when you tell people, I'm part of Primary Care Progress right now, you know, what does that mean? You know, maybe if we have a direction that would help give us more visibility, I guess. Kind of figure out.
That's a great point. Let's do a few more whys, and then let's start moving into specific what. What would this group actually do? So, yeah, Michael, please.
Well, it's a why and a what. So the why on the last page is something about direction of the national organization.
Yeah, influencing direction.
Influence direction. So
Yeah.
the thing that was most exciting to me was not just recruiting students and heads, which I've heard a lot of, like revitalizing size of the workforce, but to actually make the work different. The inspirational person, Jeff Berner, that we heard speak today, doesn't actually practice medicine. He doesn't actually sit and talk to patients. And it's the work that we're all going to do is going to look very different than the work as it's being presented to us now. And we don't know what that work is going to look like. And I think one voice that's really missing is the patients themselves. I mean, what do communities actually need? If we're the new wave of doctors that are going to change the way we deliver healthcare in America, the way healthcare is done in America, the ultimate voice ought to be the people who are going to, who need that healthcare. So I think one thing that's really missing from this whole conversation is community voices and help.
Patient voices. Excellent. Yeah, a few more on why. Aaron.
I would add to that, though. I mean, I feel like Jeff Brenner has done a really good job of trying to figure that out via research. And like research might be a tool for that. And so I would wonder, and we don't have to continue this conversation right now, but what would be the appropriate way to collect that information, whether that be focus groups. I'm not really sure what the role of PCP would be in bringing on the patient, and how that would actually materialize. But I just wanted to put that out there. I sort of see when I heard you say that, the first thing I thought was research as a method to that, but there are lots within that as well.
Well, Jeff Brenner actually has some patient representatives on his board. And they're elected by, their peers, their patient peers.
Yeah.
So that's also an option.
And one thing that's done a lot in HIV care is having a consumer advisory committee that sort of examines and works with the clinicians and researchers to sort of help guide the direction that the organization is going and making sure that they are focused on the ultimate issue, which is improving patient care.
Any other? Yeah, please.
I guess one of my questions, maybe I missed this part of it, but is kind of who would be on this board? So, and we're probably getting there.
Yes.
But I guess I can see it being very different if it's like a medical student, undergrad, resident run collective versus or including faculty practitioner. I mean, I think that's obviously a conversation it sounds like we're heading towards, but I think that will shape the voice and the direction that that kind of board would have.
Absolutely. Do you mind if we do you mind if we put that in the parking lot for 15 minutes?
Probably getting.
Hey, no, I'm glad you brought that up. Not at all.
Okay.
That's wonderful. So let's move on very specifically and hone in on the what. We've been talking a lot about the what. What would this group do? What would it focus on? What would fall into the realm of what it would really feel responsible for, and what maybe would not? So we got a lot of stuff already that we pulled in terms of the being representatives, the story of us. Disseminating information to other chapters, really being a national voice, representatives, giving the national team feedback about how it should deploy our limited resources. What other things would you want to see this group do? Yeah, please, Sarah.
This is something that I didn't get a chance to comment on during the last session, but part of the choices that we discussed, that we made, that to be open and honest with each other was a very radical choice, and a very one that we didn't all have to make, and one that the culture of medicine is definitely not in favor of. And so it feels like a story where we kind of become aware of the rock, and so what are we going to do to move the rock? And so I think that having a
Yeah, please. And would someone mind, while Melissa's continuing to describe, could we chuck these up on the back here? Would anyone mind just pulling these off so we can continue the conversation? Thank you, Sarah. So let's keep going. What pieces? Yeah, please.
I guess another piece would tend to be one thing that I've consistently heard about primary care and family medicine is that it's behind the times. So I guess one sort of direct way to combat that would be if, not just best practices of PCP chapters were shared, but best practices, if there's some brilliant article that's published in a journal, making sure that, there's some, maybe like a weekly digest of innovations in primary care or something like that, so that you are making sure to spread current research and information so people can find ways to innovate based on that.
And maybe with a specific vision towards what our constituency is most interested in, because there's a ton of stuff constantly coming out. So, people are busy. Maybe they could really hope that there would be a group culling through it and identifying some. Is that one of the things, or am I just adding?
No, that's kind of what I was trying to do. Better.
Excellent. Other ideas for the what? What about a national campaign? We talked about that a lot. We had a few ideas for national campaigns that we spoke to some of you about. But if you were to think about what would be concrete action that all the different chapters might feel really excited about participating in, that would really come together as a national initiative, with all of the media opportunities, with all of the the big scope things that could be accomplished. Any ideas for some campaigns? Have you been kicking around ideas in your head? Yeah.
I know one that already exists. It's coming up actually, National Primary Care Week. I think that's a really great opportunity for chapters across the nation to really to get things going.
Excellent. So a National Primary Care Week is something that we all do, but anything specific, any sort of specific action, specific focus that would unite all of us. Yeah. Okay.
Maybe an easy to read and understand looking at the healthcare law. Like I know for providers and consumers, I don't know if that's being done or has been done or just the dialogue about that. What is this document and how is it going to affect our care?
So Katie, let me make sure I understand. The campaign would be a campaign to inform the population about what the ACA is and isn't.
Yeah.
Okay. Good. Yeah, please.
So I think this summit went well, so maybe doing through the national committee another summit that would include more people and more tools and actual, instead of y'all giving it specific people from the chapters around the nation could give talks and maybe sessions and breakouts and things like that. So the actual students and residents themselves are the ones that are pushing primary care.
Excellent. It's almost like a train the trainers, so we can disseminate this approach to public life, this approach to change to more and more people.
Yeah.
Excellent. Yeah, please. Chris, why don't we march through this row?
What about a national campaign to educate the public about what primary care is? I mean, I don't know if you probably have read the Family Medicine Report. One of the things that they found is that people don't know what family doctors are, and they don't know what the difference is between a family doctor and an internist. They know that pediatricians are baby doctors. But other than that, they're just confused about what we do. What if that were our campaign, and it was just some way to educate the public in general about what a primary care doctor does, and that would be the starting point, I think, for then people understanding why we are valuable.
So public education campaign. Excellent. Yeah, please.
I was thinking a campaign for sort of trying to create a nationwide structure of alternative curriculum. So I know that there's accreditation boards that have certain requirements that medical schools have to reach. If we could campaign for a new requirement, I guess, for these accreditation boards to include a certain amount or a certain experience in primary care in every
Yeah, please, and then we'll come to you, Jeff.
Yeah, I think going off of that, what I was going to say was something like pressuring schools that don't have a focus on primary care to really make that part of their mission statement. So maybe taking schools that have good primary care models and sort of making them like the, not poster child, but trying to use them as examples of ways that medical schools can incorporate primary care successfully, and even putting like tangible numbers. So not just saying, like, oh, we want more primary care doctors. Like, you should have 20% of your doctors going, like, graduating should be going into primary care, not just like specialties, not just like primary care and then subspecializing, but they should actually be practicing primary care in 10 years from when they graduate.
Now, let me push you on that a little
Yeah.
bit, because a number of you have actually brought up a similar thing. We've been thinking about a similar thing. What would that look like? What would be the strategy? What would be the leverage that we use to influence these deans, residency directors?
Well, you'd have to, one, exemplify a need. So that would maybe be tapping into the patient population, using their voices and the power of their, like, patients want this. It's something people actually want.
Yeah.
And then I think also something that we've been mentioning is using people's passion for primary care. Because I think most doctors coming into medical school, I don't know. I think this is the tricky question. Is like, how do we do this? And but I guess showing that it matters to people and showing that it's something that people, when they start medical school, want, and then they sort of like lose in this process of training, and they get jaded. So showing it's a core value to medical students.
So before we end, I want to tell you about an idea that Jeffrey Brenner and Liz and I have been talking about that's very much in line with that. But Sarah, did you want to add something to that?
Yeah, just the thing that popped into my mind when you were saying that was maybe we could have like a PCP grading system for schools, because I know the Farm Free campaign has done that, and embarrassing people sometimes is the best way to get them to do things. Because UCSF is ranked whatever on that primary care thing, but I bet if we gave a grade for the way that they actually relate that in the culture of their school, it would be very, very low.
Yeah. Embarrassing these schools is just short of beating them with cat's crutches. So that's good. There was Brian.
Well, it was just another way of tackling that, and I don't know that this is the best idea, but it was one that came to mind. It would be something like the Declaration for Human Rights. Like, that is something that they create this document, and then they went to these countries and said, basically affirm these rights or whatever. Most of them did. You could have a declaration for primary care and then take that to schools, and it would be obvious stuff that anyone who was reading it would understand it, just explaining the importance. And basically just ask the schools to do exactly what they did at Harvard, reaffirm your commitment to primary care given the problems that we have right now, and then see who pushes back on it.
Yeah. Liz, do you want to share what we were talking about together and that Jeff Brenner came up with, or do you want me to? I hate to put you on the spot.
I'm happy to talk for a second.
Yeah, sure.
You can kind of add on.
Yeah, sure.
I don't know if I just
come on.
down, yeah. So we've been talking about, as Andrew has kind of conceptualized it, a compact, which I think is very akin to like the word declaration a little bit better.
Yeah. But you love the word compact.
I just think it's a make our compact. It's just weird. Anyway, basically, I think the idea is pretty well encapsulated in the way that you described it. I mean, a set of principles that students, chapters could take to dean's offices that sort of were generated organically by us as students or trainees, with some guidance perhaps from experts like Dr. Brenner, to sort of ask or demand that primary care be better integrated into curricula, that we are provided better support as trainees headed in that direction. I think that pretty much it.
Yeah, no, absolutely. It almost could be, I mean, there's so many different ways to cut it. When Liz and I were just brainstorming, and Larry Bauer of the Family Medicine Education Consortium has been another person behind the scenes who's just been thinking about this. But, it could almost have like 2 or 3 parts. The first part is statement of principles. Primary care is really important. The nation has major health problems, and our poor investment in primary care is a major cause of that. And we believe med schools have a responsibility to be part of the solution. A set of common demands that maybe we could all agree on, whether that's number one, tracking. So publicly track and report your primary care output. We've all heard of the Dean's line, right? The Dean's line means deans are asked, what's your primary care output? And they say, oh, it's 35 to 50%. What they're doing is they're counting people going into internal medicine residency and pediatrics residency as the primary care output. It's not primary care output. The vast majority of those people go on to subspecialize. The numbers are much lower. So they need to track and report. So that might be one thing. Second thing might be exposure to new models of care delivery, the medical home. Another thing might be interprofessional training. I mean, there are different ways to cut it. And then maybe there's a space for that local community to have a town hall and identify what it believes that medical school should do, signed by the undersigned, which includes patients in that community, payers with an interest in better primary care output, faculty, students, residents. It could be pretty broad, but that's the basic concept. So that's one idea, but let's keep going, Michael.
I really like that idea a lot. What I might add to it is another output is tying the work we're doing as a professional guild, as you will, like primary care practitioners, to the actual outcomes that matter to people, so the health outcomes. So one thing I hope we can do in Buffalo is we're going to try to do these innovation collaboratives to get students involved with childhood obesity at resident clinics. And then the ultimate goal is that childhood obesity will go down at the resident clinics. Now that's a big goal, but like, could you have something where like, you know, all the resident clinics at all the med schools that sign into have to like track and report that they're improving hemoglobin A1Cs for all their patients in the population, or reducing hospital admissions, or some outcome that actually matters to the population more than just the professional guild that we are.
Right. That's a great point. Many medical schools would feel very challenged if we asked them to commit to their community's health. I know that the medical school I'm affiliated with would experience that as a direct assault. Let's keep going. Other thoughts on this concept that Liz brought up before we keep going with others? Yeah, thanks.
So I think that's a really good idea. I don't know what keeps schools, like, I come from Harvard Med, so I can very easily see Harvard be like, yeah, that's something for other schools to worry about. We'll continue doing our Harvard thing. And I guess I don't see what's, they have the power and like what gives you the power.
Liz, walk us through the history of the Farm Free, because
right,
I think there's a lot to learn.
Farm Free is very instructive here, although I do think it's important to differentiate the model of sort of pressure that we're talking about here, because I think it's a little bit different, but actually Harvard's a perfect example of where the Farm Free campaign has been really effective in sort of pushing, through public shaming. There was, I don't know if you all were around with the New York Times piece and all that sort of stuff, where, Harvard, I believe, scored was either an F or a D for the first couple of years, revamped and announced their new conflict of interest policy in 2010, I believe, and, now scores an A, and, a lot of that is attributed to the fact that they were kind of publicly shamed, and has subsequently, that change policy, I think, really raised the bar for most other medical schools in the country, because now Harvard's sort of the model.
Yeah, so it's not just approaching them with holistic principles, it's also this grading system. Because, I mean, for example, the U.S. didn't sign the Kyoto Protocol for a really long time. They're just like, yeah, we're the U.S., we're going to do whatever we want.
Yeah.
So.
And I think that if we really were to kick off something like this, I think we'd have a whole strategy. I mean, I've talked to some deans about this just very quickly, and some of them have been like, oh, we're already doing that. Where do we sign? And we said, well, it's not great, it's just an idea. So I think it would be a campaign of going after low-hanging fruit, building momentum. So when it came time for some of these orphan schools, maybe places that don't have family medicine, that would be like, whoa,
What schools like
there would be like reporters, reporters getting in their face saying, you're not signing the primary care compact? What kind of horrible people are you? Dibby.
One strategy I was thinking of is to do this, like, I heard that you pressure schools into changing their mission statements or something like that, but there's also, you could also find ways to show them that primary care can fit into their mission statement as it stands. because I'm thinking of Yale, which is kind of similar to Harvard. They'd be like, well, Yale's goal is to chuck out leaders and not primary care, right? And then you could be like, well, why can't Yale chuck out leaders in primary care? You know, or kind of like, you know, you mold it into their mission statement as opposed to like, you need to change your mission statement.
Yeah.
Or, you know, like, I mean, I see the pressure there, but like, there might be, that might be one way to.
Absolutely. And that was our strategy at Harvard. When we were initially putting it together, we sat down and really thought about the school and their self-interest, and we said we'd love to convince them to turn out more primary care providers, but that's not in their self-interest. They're interested in innovation and leadership. We're interested in primary care. Maybe we could find that overlap area, innovation in primary care, and we knew at the end of the day, though, that would turn out more primary care providers. So we sort of sucked that. Yeah, man.
I think in any sort of argument or debate, it's really great to have perspectives from outside of the proponent of the argument. So I think one thing we haven't talked about is how do we expand our support base outside of the primary care sphere. I know that we as primary care professionals or interests are already band together as a solid group, but how can we make our stand stronger? I think we should include perspectives from specialists who also feel that primary care has a role, or reach out to, you know, fledgling students like the undergrads. Sorry, I keep thinking undergrads. But I think just reaching out beyond the sort of medical students within primary care sphere could really boost up our momentum.
Sammy, last comment on the what could we do, and then we're going to move into the sort of how, you know, how would we organize this? Just brainstorming. We're just brainstorming here. Yeah, Sam, please.
So I was just thinking that, I mean, if you want to convince medical schools to change things, you kind of have to hit them where they care most, or I guess where it hurts. And what they care most about is U.S. World News rankings. So if you can convince U.S. World News to include 10-year primary care retention in their methodology of primary care rankings, then they'll change. Second, if you want to include medical education to have more, or to teach more about primary care in just like medical education, you got to get more hurt. You've got that double AMC to put that into step 1. They're going to put that in the curriculum. So, I mean, honestly, I think that's how you do it. I mean, it's great.
Sorry.
Keep going, Sam.
I guess I was briefly talking with her, and she was just saying like WFP does have like certain rankings and times, but rating systems, but med schools don't care. But they will care about step 1, and they will care about what U.S. World News says.
Sammy's back hitting people where it hurts. I like that. Okay, let's move on. We got 7 minutes left. So just brainstorm, like, you know, not necessarily what would it have to, how would we have to organize this to convince you to take more of your time to be a part of it. But let's say you were trying to pitch this to a friend to convince them that this is worth their time, being a part of this committee. How would we organize it? Who would be on it? And we're not looking for consensus here. We're looking for ideas. How often would we meet? How would we meet? Let's hold off on how we make decisions. But what's your sense of that? Let's start some ideas here. How would this thing look? Yeah, Joe.
Well, I mean, it seems obvious we should have a representation from each chapter on the committee.
Our group was strong for regionalism. We had Buffalo, Yale, kind of in the Northeast. That seems illogical.
Okay, so regional reps versus chapter reps. Other ideas? Yeah, please.
I'll say as an internal medicine resident, I think it's important to remember to include all primary care specialties, because although not all internists go on to practice primary care, I think there are a number who do, and you have to kind of, I think, be careful. Part of that is that you want to make sure they include all those views, so that you're continuing to encourage those people who go into general pediatrics or general internal medicine, because you want them to do just that.
Yeah, and let me ask you a question. Maybe it's not just to you. So, you know, when primary care is thought of, it's thought of family medicine, internal medicine, peds, obviously, you know, nurse practitioners, physicians assistants, other providers in that realm. Other disciplines that you guys think of as, you know, primary care. OBGYN is sometimes included.
Yeah,
What do you guys think about that?
I just have one example too,
Yeah.
and then I'll be done. I think it's also, like, when we're thinking about the specialty stuff, so one of the best residents in our program in our primary care track is actually going to be doing an IV fellowship starting next year because he will be an HIV primary care provider. So that's his plan, is he's going to manage the care, IV and otherwise, for patients who have HIV in our special need population. So I think the other thing to kind of keep in mind when thinking not just about other broader specialties is that sometimes there are specialty providers who are practicing primary care, and their voice is also kind of important.
Absolutely. Other voices we have here, yeah.
We might want to consider massage therapy and alternative medicine maybe.
Excellent.
I would throw in mental health as a huge one. It's frequently left out, and they're always upset about it. So
yeah, that's a great question. Other concepts on the who part? Yes, Sarah.
Well, I like that idea that was mentioned earlier about what about specialists? Like, would it be a benefit to have a few people who were kind of friendly specialists? Because it's been alluded to a lot that, you know, the potential of a campaign like this is hurting a lot of feelings and turning a lot of people against the movement. And would it help not only to guide us about how to proceed cautiously and with the being most efficacious, but also about having the ability to say, look, this person's a cardiologist and they support this. This person's a surgeon and they support this. So I'm not sure what that involvement would be like, but it seems to consider.
Yeah, and I think, Sarah, you raise a great point, which is that we have to know that as health reform moves forward, as payment changes, as payers flex their muscles to change the way providers operate, as systems respond, there's going to be a squeeze. Primary care is getting squeezed to provide better care. Specialists are getting squeezed, and there's a lot of potential for an us versus them. There's a lot of potential for specialists to be unhappy, and we've got to be positive. It's got to be inclusive. You know, the healthcare of the future has a big team, and specialists are an incredible part of it. And as more and more, like I have a lot of end-stage renal disease patients who, in the future, their primary care doc is going to, or provider is going to need to be a nephrologist. And it's just, and they're going to need to be primary care providers. So I think it's a great point. Other concepts on the who before? Yeah.
I mean, though hopefully healthcare reform will sort of move us away from this, but I guess another specialty that you might want to consider is a lot of ED docs are sort of de facto primary care physicians at the moment, so making sure that people who are on the front line of patient care and ED also have a voice and helping decide where primary care is going.
Excellent. So how about the sort of how, in terms of how often? What do you think, Sarah?
I have another who, which was like health, economics people and law and those kind of voices, because it really seems like if we could be the group that is the best prepared and training doctors that are the best prepared, because we are actually training people to be inclusive of all these things that medical school was not. I don't know about that.
How long should we ask someone to be a part of this? How long would we ask people to commit to being a part of this group, this steering committee, this executive committee, this club, whatever you want to call it? Yeah, please.
I mean, I think a lot of how it's organized, including the duration of the time and the time commitment, is going to depend on what that goal is. And I think if you have a big goal, it's probably going to be really beneficial to have a group that can meet, fairly frequently and for a fairly long time to get that sort of seen all the way through. But that might not necessarily also be the way to get the most perspective included, because everyone's really busy. So I think there probably is going to need to be some kind of balance between those two things of how big a goal you want to achieve and how big a commitment you want to ask for people, because you kind of need both. But you also have a very, it's a community that already has a lot on its plate.
Yeah.
So.
I'm wondering if we could ask our colleagues from FMIG, Ashley and Liz at AMSA, if there are things we can learn from how other organizations, not necessarily your own, but you guys have been in the field for a long time, what we could learn from other groups in terms of how to structure this, the pearls.
You're wanting us to give you our secrets.
Yeah. How do you guys meet?
Actually, I'll defer to me.
It's classified.
Yeah, no,
people serve for? How often do folks meeting?
So I think it really depends on stages. People always go through transitions, and so to understand where those transitions occur. And you know, here we have a broad range undergraduates through practicing physicians, and so for me that was interesting to see that range here. For a medical student, you know, it depends on the year of medical school. I think for a physician, it probably depends on the stage of development and how connected they are to maybe another organization or their availability. So, as was said before, it really depends on what the goal is, I think. So I know it's not a very concrete answer, but undergraduates might have more time to help with the grassroots organization. So it just depends. I think it depends on the level of training. It depends on the level of training and where the person is in their.
Excellent.
For med students and residents, we don't require for more than a year ever, unless they're on the ACGME group, and then that's a 3-year requirement. Other than that, everything's a year.
Okay. Liz, any last thoughts? Because it's getting to 5.
Sure. Just drawing on that farm degree experience for a second. I think one of the things that was sort of essential for that coming to fruition, you know, several years ago, was having a core group of people who were able to work on it over time. So we tend, in this context, to work on year-long cycles with the opportunity for people to stay on for additional years as their training and sort of their commitments permit. So sort of a re-upping every year. That sort of thing.
And we're different too. We're a large specialty organization with over 500 staff. So it's not the same context.
Right. Well, listen, it's we really hope you guys see this as the beginning of a conversation, and we're excited to push it forward. So just remember, participating in the conversation doesn't necessarily mean that you're putting your chit in the game, saying, I'm committing to being on this this team, whatever it is. But we want to continue this. So what we're going to do is we'll collect these thoughts, organize them, and also organize a follow-up meeting for anyone here who wants to continue participating in this discussion of what this could look like. But I think we're really looking to get this up and rolling sometime this fall / winter. So listen, it's 5 o'clock, 5:00.